Good morning, everybody. Welcome to Pediatric Grand Rounds, and specifically today is the Treuman Katz Bioethics Grand Rounds. The voice you hear is Suzanne Mazer. I'm Director of Continuing Medical Education here at Seattle Children's. So I'm going to turn the virtual microphone over to Dr. Doug Opel to introduce our speaker and take it away. Thanks, everybody. Thanks, Doug.
Welcome, everybody, to the 14th Annual Treuman Katz Lecture in Pediatric Bioethics. As Suzanne said, I'm Doug Opel. I'm faculty here in the department and Associate Director of the Treuman Katz Center. Before introducing our speaker, I wanted to take a few minutes to acknowledge Treuman Katz, for whom this lecture is named. Treuman was a president and CEO of Children's from 1979 to 2005, so for 26 years. And he was recognized really for his visionary leadership. He guided Children's to financial stability. He developed broad-based community support for the hospital and its mission, and he expanded pediatric subspecialty services at Children's and through regional clinics so patients and families could be seen close to home. During his tenure at Children's, some of his accomplishments included the development of a strong and effective partnership between the University of Washington School of Medicine and Children's that really serves as a model program for other academic private partnerships. Another accomplishment of Treuman's was his commitment to developing the first Center for Pediatric Bioethics, which really emerged out of his longstanding interest in quality of care and respecting the role of families, as well as an emerging appreciation of the role of clinical research in advancing pediatric healthcare. So in honor of Treuman and his incredible achievements, the Seattle Children's Board of Trustees established the Treuman Katz Center for Pediatric Bioethics now over a decade ago, as well as this Treuman Katz lectureship in pediatric bioethics, which occurs annually. So thank you, Treuman. Let me now introduce our speaker for today. Dr. Denise Duzinski is professor and chair of the Department of Bioethics and Humanities. She's also an adjunct professor in the School of Law and in the Departments of Family Medicine and our Department of Pediatrics here at UW School of Medicine. She's also the chief of the UW Medicine Ethics Consultation Service. She's both a leader in the field of ethics locally, but also nationally, having served on the American Society for Bioethics and Humanities Board of Directors. And she has numerous scholarly and research interests ranging from ethical issues in transplantation to large-scale adverse event disclosure to ethical issues in end-of-life care. Today, though, she will be talking about health equity in the context of COVID-19. So please join me in welcoming Dr. Duzinski. Denise, I'll turn it over to you.
Thank you so much. I just want to say I'm honored to be invited, honored to be here. Thank you, Dr. Katz and the Treuman Katz Center, as well as everybody at Seattle Children's. So first thing is I have no disclosures. My goal today is to sort of reconsider the usual way that resources are allocated and try considering the well-being of BIPOC, Black, Indigenous, people of color communities first. So broad social justice issues like racism and justice are complex and can't be solved in an hour or a year or 10 years. Still, I invite you to focus narrowly on one very important aspect of social justice, and I take for granted in this presentation that structural racism is pervasive and harmful, and that racism is a public health crisis. I think we need to look at the problem of COVID-19 resource allocation with a new orientation, with this little cutie upside down, perhaps even upside down from the way we've often looked at it, in order to reach health equity. And we have to do things differently, and I'm hoping that today we can work on that together. Unless you've been living on Mars, you know what's happening in the world and in the United States in terms of COVID-19. Just to orient all of us, here's some of the most recent data around COVID-19 with many, many cases and deaths within our institution, within our country. The good news is that rates among children are low, thank heavens. So we can celebrate that. Certainly children who are very ill in our region look to many of you on this call for help, and I want to thank you for that. And Of course, children are also indirectly impacted when the adults in their lives are ill, when there are school closures, reduced access to school lunches, less social interaction with other children, etc. But at least this is some good news. Unfortunately, it's followed by some bad news. So the disparities that are affecting adults are also affecting children. Roughly 75% of children who die from COVID-19 are minorities. So the coronavirus has killed at least 121 people under the age of 21 across the country. Of these young people, roughly 3 in 4 were Hispanic, Black, American Indian, or Alaska Natives, suggesting without surprise that the virus is disproportionately killing young people of color, especially those with underlying conditions. In the realm of healthcare ethics, you can't really separate distributive justice and health equity. They're intimately intertwined because the allocation of resources must abide by fair rules of distribution, and those rules cannot be capricious. So if there are deep inequities predating or influencing the distribution, the principles of distributive justice come under scrutiny. And that's precisely what we're seeing with COVID-19. What seems to be fair and equitable to one group simply perpetuates the discrimination of another. This is a tough situation and one that I think we can do better at, but it's going to take a lot of work together. Let me define distributive justice. This is essentially the fair distribution of both benefits and burdens among members of a society. So for example, the burdens there might be something like taxes. We all are taxed, but is the taxation fair? So we are looking at both of those things together when we talk about distributive justice. And what do we mean by health or healthcare equity? Care is in parentheses because we provide a lot of health care in the jobs that all of us are in. But the broader goal is health. And actually, as many of you know, healthcare is a very small part of the contributions to a person's health. So you can see a couple of the definitions here. Health equity is a form of justice, and it's providing care that does not vary in quality because of personal characteristics, such as gender, ethnicity, geographic location. And it's the absence of avoidable, unfair, or remediable differences among groups of people. It implies that ideally everyone should have a fair opportunity to attain their full health potential and that no one should be disadvantaged from achieving that potential. Health disparities, of course, are underlying all of this, and those are defined as differences in the quality of health and health care that mirror differences in socioeconomic status, racial and ethnic background, and education level. So we're grappling with both. So here, there's a lot here. So this is basically one of the tables from an article that came out early in the pandemic by one of our colleagues, Zeke Emanuel, who is a physician and also runs the ethics program at Penn. And I want to point out a few things here. So there's a lot of agreement. Of course, this is not the first pandemic or large-scale infectious disease that this country or the world has seen. So we have looked at these issues many, many times before. So this is sort of a review of what we pay attention to as ethicists and as clinicians as we try to allocate. So the first thing I want to point out is that there's a high priority for what we call a utilitarian framework or a utilitarian allocation system. This is where the goal is to maximize benefits and minimize harm among a broad population of people. This often is construed, especially under the current circumstances, as saving the most lives. So the people who are likely to be saved from, let's say, ICU intervention, should we have not enough of those, would receive highest priority for that. This basically is a taken for granted standard of allocation. And there's a lot that's good in this standard. However, I think it needs to be balanced with some other things, and I'm not alone in that. So the next box that you see outlined there is something called instrumental value. So Zeke and his colleagues here are making the point that there are certain people who might need priority. This would include healthcare workers, because they are keeping them well keeps other people well, right? Both in terms of infection, reducing infection rates if they're in contact with a lot of other people in the public, but also because they're providing healthcare, which helps other people be well, and we need them for the infrastructure and in order to get better under these circumstances. And that's also often in tension with this last box, which is giving priority to the worst off. So we have, many of us have an inclination to say those who are the worst off might have higher priority under many circumstances, but that can be in tension with that utilitarian framework. And I want to see if there are ways we can begin to reconcile these things when it comes to BIPOC communities. The other thing I want to point out here in that second box is this also has to do with something called reciprocity. So the idea that healthcare workers, for example, should receive, let's say, some priority consideration in the allocation of ICU beds, vents, or vaccine is based on the idea that they're giving a lot and sacrificing a lot for the well-being of the whole, and that they are owed this reciprocal benefit in light of that. So that will come up in a moment as well. All right. Oh, let me say one more thing. The recommendations from this paper are several. First, I'm just going to highlight three. First, priority for limited resources should aim both at saving the most lives and at maximizing improvements in individuals' post-treatment length of life. Second, COVID-19 interventions, testing, PPE, ICU beds, vents, therapeutics, and vaccines should go first to frontline healthcare workers and others who care for ill patients and who keep critical infrastructure operating, particularly workers who face a high risk of infection and those whose training makes them difficult to replace, and that includes a lot of skilled healthcare workers. The third recommendation is for patients with similar prognoses, equality should be invoked and operationalized through random allocations such as lottery rather than a first come, first serve allocation process, which that first come, first serve tends to give priority to those who have resources and privilege in a way that they're able to get to the hospital more quickly than others who might get sicker before they come to see us. Recommendation 5, or the last that I'm going to cover, people who participate in research to prove the safety and effectiveness of vaccines and therapeutics should receive some priority for COVID-19. Now, I think we want to honor all of these priorities. They come from a place of considered moral judgment. And at the same time, I think I'm going to press them a little bit to see how these play out in BIPOC communities. Here you can see, just generally speaking, some of the distinctions, certainly not all, between sort of a public health orientation and our usual standards of care. So you'll see on the left side, usually we're trying to respect patient autonomy. There's fidelity to each patient or patients in our group. And not all who could benefit receive treatment, but that's due to a lack of access or insurance. In a public health orientation, we're not oriented toward the individual, we're oriented toward the well-being of the whole. And so it's about the common good, not individual autonomy. And we're allocating population-wide. So here, once again, not all who could benefit receive treatment, but this is now due to scarcity. And certainly while we haven't had crisis standards of care called in our region or our state, there's no doubt that we have had to consider these things as the pandemic has played out, let's say, in terms of PPE, for example. Okay, so here, I want to just talk briefly about a few of the things that have been distributed, of course, in terms of our distributive justice. So let's think about testing. Those with health insurance were the first to be tested because you needed a doctor to get the test, and the tests were scarce, resulting in health inequities. So, now we have UW Medicine along with King County Public Health has vans going out to some of the underserved communities in South King County, for example, but they can only test 200 people per day, and the demand far exceeds that. So you begin to see the inequities, of course, with testing. So some of the most vulnerable communities were last to get tested. With PPE, of course, we were dangerously low early in the pandemic. And need not be said, but adequate PPE protects healthcare workers and patients. And if you don't have enough, all of those people are at risk. So the question is, now that some of these shortages have been addressed, or we're figuring out how to allocate throughout this long pandemic, the question is PPE protecting our healthcare workers, and is it protecting the public? And a lot hinges on this question. In triage, when there aren't enough ICU beds for everyone, for example, when we're in crisis standards of care, let's imagine there aren't enough beds for everyone who meets clinical inclusion criteria. How do we decide who gets one of those beds? So multidisciplinary triage teams are charged with allocating ventilators, for example, if we moved into crisis standards of care. And in the interest of equality, triage teams are to allocate blindly without knowing the background race of their patients. But BiPOC patients are more likely to arrive with multiple comorbidities, thereby reducing their chances of getting a ventilator in the first place. So, and we can't act as if racism wasn't a factor in their illness to begin with. So the triage process itself can end up creating another barrier to fair allocation to BiPOC patients. Finally, vaccine. When we get an effective vaccine, and that's what I'm talking about here, who should get it first? And what if the first available vaccines aren't as effective and have unforeseen side effects? How do we make sure that is fair? Okay, here we see what we've seen often, which is some here need more than others. You see a difference between equality and equity. Equity sees the disparity that some will need more to reach that apple than others, and addresses it rather than settling for everyone having an equal share. And we know that a major contributor to health inequity is racism. So you can see some specific examples about how justice and fairness might look different depending on where you're standing, from a privileged position versus an underserved position, right? Some of these I've talked about, but drive-through testing really opens up a lot of possibilities, but if you don't have a car or limited access to a car, this can be difficult. If limited English proficiency is a factor, that can make things more difficult. If you live in close quarters and must go to work, these are all limiting factors which say that there are already disproportional access to these important healthcare resources. The CDC has noted several factors that contribute to increased risk in BiPOC communities. First and foremost, discrimination, which leads to poor health, along with many other things. Occupations, certain occupations, including being a healthcare worker, where you're in close contact with the public and you can't work from home. And then housing, multi-generational, more people living together puts people at higher risk just because they're close together. Let's look at a little bit of the data here. So we already know that, this is from the CDC, that the older one is, the greater the risk. This is, you can see 75 to 85 plus years old, incredibly high vulnerability to death. And so we need to take those things into account, because if we're going to manage that utilitarian standard with helping the worst off, this is where that tension lies. So clearly there has been some attention to making sure that our elderly population get a bit more resources and attention. Here you can see the comorbidities that significantly influence one's susceptibility to COVID-19. And you can see, as we will see in more of this data, that racial and ethnic groups are more likely, they will suffer greatly from these, or greater than white communities from having these comorbidities. This is staggering data. And these communities need outreach and help, just like we're doing with, let's say, long-term care facilities. But there is no disputing that the communities on the left-hand side of this graph are at higher risk and therefore, in my opinion, need more help. need more support and assistance. And this is another way of looking at these data. So Blacks are 4.7 times more likely to be hospitalized and twice as likely to die of COVID-19 than white non-Hispanics. Hispanics are 4.6 times more likely to be hospitalized and 1.1 time more likely to die. And American Indian Alaska Native patients are 4.3 times more likely to be hospitalized and 1.5 times more likely to die. This should really influence what our allocation schemes look like. Okay, just looking at some of those comorbidities, looking at asthma, for example, Black Americans are 3 times more likely to die from asthma, and Black women have the highest rates of death due to asthma. So, and that's just one of those comorbidities. Another, you can see here from this chart, a comparison of white versus Black and Hispanic patients who suffer from, if you look at that bottom section, either hypertension or diabetes, and you can see the comparators there with 31, or let's say in the 65 plus years of age, 55% white versus 78 to 79% in the Black and Hispanic communities. So we've got plenty of data, though I feel like it's important to review it. Other important information related to racial disparities, Black Americans with greater rates of chronic disease associated with more vulnerability to COVID-19, and they're working in jobs with a lot of public contact, both making them more susceptible to infection. We also see that Blacks compose 17.5% of all healthcare workers. You can see that on the right. In addition to chronic diseases, those in essential jobs are at higher risk, and Blacks are more likely to be in those jobs, comprising, for example, 26% of public transit workers. Then we can look at something like generations in the household, which is also a risk factor. So when you live in close proximity, and of course, when you have susceptible populations living with other populations like younger people who tend not to get as sick, this can cause those older people to get sick. So Latinx and Black workers are more likely to live in these multi-generational homes, and you can see the data there. In addition, Latinx and Black workers are more likely to live in densely populated housing structures, also a risk factor for COVID-19. Quite a bit, there's quite a bit of a disparity there. And just nodding towards socioeconomic disparities, you can see here a giant poverty and wage gap concerns between white and Black Americans, with the overall poverty rate for Blacks being 20.7% compared to 8.1% for whites. So this is very real and will play out in terms of how people have access to health, how healthy they are from baseline, et cetera, and relevant, of course, to COVID-19. So I come back to this question of looking at the allocation problem differently. I want to propose, and I know ethicists talk about issues that reasonable people disagree about, and this will be one of them. So, but I do want to really think about the prioritization for healthcare workers to receive vaccines, for example, and whether this should be re-examined if we want to consider carefully prioritizing those who are at the most risk and the worst off under these circumstances. Not because healthcare workers are not at risk, they are, or not because they aren't owed gratitude, respect, or reciprocity, but because the greatest suffering and harm is occurring in these other communities, and that would lead one to believe they should get these resources first. So I'm hoping we can discuss that, understanding that there will be differences of opinion there. So here are some, there are tons, and actually Dr. Diekema, who's with Treuman Katz, and I think Aaron Whiteman, as well as a colleague here, Nancy Jecker, wrote a very good commentary on this. But when you look at some of the reasons to or not to provide preferential access to scarce medical resources for healthcare workers, and here I'm talking about vaccines and ICU beds, ventilators, et cetera. We have both the reciprocity and the instrumental value argument, which are really compelling. People pay a lot of attention to those. And there's also a concern that without reciprocity, healthcare workers might leave the field when we most need them, getting burned out. And there are a lot of things I think that healthcare workers are owed because of the burden that they are carrying, and that there's more that we can do for them to help them. But on the no side, the real worry, the first worry for me, is that the stewards of those resources get them first. And I think I think that's a problem. I think in general that's a problem. And we need really strong justification to make that work and to say that's ethically justified. And I don't know if we have it here. Those ill enough to need ICU level care for COVID-19 versus other illnesses require a long recovery. And so the idea of getting them back to work to continue to help other patients is not it's not going to be a quick thing, and people may have some long disability time. So that instrumental value issue, I think, comes under question. Most of those healthcare workers will be white. I will show you a couple of demographic information. This is important too, because by prioritizing them, we end up prioritizing white people. And where PPE is adequately protective, those at risk without it should go first. So if you guys are reasonably protected with PPE, maybe others who are not and who are in those essential jobs should go first. Certainly, if the PPE is inadequate, there is a greater claim to healthcare workers for a vaccine or for some of those healthcare resources. So you can see here some of the racial and ethnic diversity of nurses, and you'll see mostly white and 23.6% Black or African American, as well as 7.5% Hispanic. And here, in terms of physicians, who also have a lot of privilege because of education and other things, most are white or Asian, and we have 5% who are Black, and you can see some of the breakdown here. So we end up looking at healthcare workers means lots of white people. Now, of course, doctors and nurses are not the only people who are essential workers, essential healthcare workers. So there are others, such as environmental services staff, and this is a very nice small documentary interviewing some environmental services staff at Duke. It's worth checking out. It's called Keepers of the House. But they also play an important role, and certainly may include some of the lower paid positions, may include more BIPOC community members, and that's relevant as we think about fairness. The question for me is, which comes first, healthcare worker or BIPOC community? So are healthcare workers at higher risk of infection or death? I think the answer to that is yes, at least to infection. So here you can see most of the data we have on this is early in the pandemic. So these are healthcare workers in both the UK and the US who had positive tests for COVID in that 1 month period between March and April. This is from smartphone surveillance data, but also keep in mind that it may have been that healthcare workers were also being tested more than the general public, because nobody was being tested without symptoms, and there were not as many tests. So it's important data, but can be hard to interpret sometimes. Here also is a study with, you can see most healthcare providers with COVID-19, 90% were not hospitalized. However, severe outcomes, including 27 deaths, occurred across all age groups deaths were most frequent in those aged over 65, which is what we would expect. So again, you ask, is it being a healthcare worker that puts you at risk or being over the age of 65? And certainly there's a little bit of both, but we certainly see that those over the age of 65 are at greater risk. Here is a study looking at in the months of March and April when PPE resources were critically low. Here you can see incidents of infection related to adequacy of PPE. And frontline workers in the UK and the US had at least a threefold increased risk of infection. So there is definitely an increased risk for healthcare workers. But now I want to tell you that there was a five-fold risk for minority healthcare workers. And PPE was more likely to be reused or inadequate among minority healthcare workers. So the study found that there was an increased risk even among those with adequate PPE during this time. And this was also done prior to some of our reprocessing efforts to try to do a better job of reusing the scarce PPE that we had. And hopefully, I don't have the data right here about how effective those are. I'm sure there's competing data. But the other thing I want to point out is that in systems like UW Medicine, for example, we don't distinguish between occupational and community-acquired infections for healthcare workers, which is the ethically appropriate thing to do, and not to worry about that. But it does raise the question, if we see more people from BiPOC communities who are more affected, it raises the question of if that's community or occupationally acquired, because BiPOC communities are at higher risk in general. So how are things now in terms of PPE? Again, not great data, but most healthcare systems ration PPE to ensure they have enough for the duration of the pandemic, which could be long. Lots has been written about those perilous spring months where really the PPE was definitely inadequate, and reuse still does occur. But shifting our practice from how we used to use PPE when we had ample supply to how we use it when we don't have ample supply can feel scary, but it's not always dangerous. So many studies have pointed to the fact, for example, that respiratory virus epidemics to date suggest surgical masks are not inferior compared to N95 respirators for many procedures, not all, of course, in terms of protective efficacy among healthcare workers. And so that's something to know and something that we learn to keep in mind when we think about efficacy. COVID-19 is the likely cause of death however, for 922 healthcare workers to date. Now, this is based on, this is compared to the CDC data, where you have, this is the most recent data from the CDC about deaths and cases among healthcare providers. I would distinguish between cases and deaths, of course, because some cases are either mild or there are no symptoms, et cetera. So we want to talk about the harm of the infection, not whether someone is infected per se, although those two things are tied, no doubt. So I asked the question, which is riskier, being a healthcare worker or being Black, Indigenous, or a person of color? Here again, healthcare workers of color are nearly twice as likely as whites to get COVID-19. And they're more likely to report using inadequate or reusing protective gear, and nearly twice as likely as white colleagues to test positive. Minority healthcare workers are likely to care for minority patients in their own communities, often in facilities with fewer resources, and those workers may also see a higher share of sick patients. Here's a little more data about that first study that I told you about, which is related to, you can see here that so this is both in the UK and in the United States through Kaiser. The majority of the people that they confirmed, because the way people reported here had to do with just calling into the newspaper and reporting that a loved one had died. So now they're confirming those reports. 103 of 167 were people of color who died, and at least 53 deaths were among those born outside of the United States. again, I think this is really compelling data that the highest risk is being among these member of these minority communities who've been historically discriminated against with less access. Now, I want to turn toward some data about vaccine, and hopefully it'll give us plenty of time to talk after this. So the National Academies of Science, Engineering, and Medicine have drafted an allocation scheme for vaccination, which went out for public comment. So we don't have the final yet, although I think it's coming out very soon. If we see, and here you can see this third bullet here. So one of the guiding principles is we should treat people equally and this includes rationing based on criteria such as race, ethnicity, or national origin. And this makes a lot of sense if you're thinking about, let's say, people with privilege, including white people, kind of taking everything from those for whom we've discriminated against historically. But it doesn't work as well the other way. In other words, if we see data that says that BIPOC communities are suffering most, then claim in the name of equality that we shouldn't consider race, we abandon health equity concerns and let systemic racism prevail again. So this is this weird convoluted, this looks right on paper, right? We don't want to discriminate. And yet, given the data that we've seen and historical discrimination, it looks like maybe we should be considering race. In fact, we might have an obligation to do so. So let's look at the scheme here. So hold on. So here you can see that the highest risk workers, the high risk workers in healthcare facilities and first responders are first on the list for allocation of vaccine. Now, I want to say this has been true in a lot of allocation schemes, especially for flu, many times before. So we kind of just take it for granted that these folks are going to be at the top of the list. Notice that older adults are further down on the list, even though they are the most susceptible to complications of the disease. So again, there are good reasons to put healthcare workers high on the list. The question is, are those good enough reasons to put other groups lower down? And we can't use race according to that criteria I just showed you. So now we'll be looking at things like what kind of jobs people do, et cetera, as we move down. So you can see here the rest of the list. People in homeless shelters, critical risk workers, the second group who are at moderate risk of acquiring infection, those are lower down. And I just want to, again, turn this upside down. What if we look at this differently? So so we're looking now at vaccine access. Basically, some of the pros and cons to preferential access for healthcare workers are similar to what we saw before. I think one thing that's important to note is logistically, it's easier to vaccinate healthcare workers. We can find them, we know who they are. It's easier to go, this is the group we're going to vaccinate. And I would not be surprised if this logistical consideration was actually quite a compelling factor here. I'm not saying that any allocation or logistical plan would be hard. I think they will be hard no matter how you slice it, but we don't want to fall back on that just because it's easiest if it doesn't meet our ethical standards. We certainly do want to protect the health of skilled healthcare workforce, absolutely. But if PPE is protective, then I would say other groups have higher priority. And certainly one of those priority groups are healthcare workers without adequate PPE and serving vulnerable communities. But one approach to that might also be share PPE with those folks as well, if we want to allow that vaccine allocation to go to other groups who are maybe suffering even more. I think the other thing is that even though reciprocity is extraordinarily important, I don't think there's enough ethical justification for that being a reason to prioritize healthcare workers when other groups are sick and dying at such high rates. Okay, so, and let's see. There are a couple of alternatives. I'm just going to go through one here to this um, approach. And this is the University of Pittsburgh model. They've done a lot of really good work in this area about allocation of medicine, including vaccine. And you can see here, the idea is to use an area deprivation index scoring system. And I'm sure some in this audience know more about this than me. And I'm sure there are certainly downsides to this. This can go beyond targeting certainly just racial groups. It could include but just based on demographics. It could include both privileged and less privileged groups. So it's not a perfect system, but it seems to do a better job of getting at some of the disparities that inform the distribution of harms from COVID-19. This approach also honors a utilitarian commitment, given the data that we have about communities at greatest risk for severe disease. So here are you can gather from my presentation some of the ways I suggest we do a better job of reaching toward equity. And it could be, those communities on the left are at very high risk. I'm sure there are more. And you could, for example, I think BIPOC communities should have some priority in how we do that. Maybe the area deprivation index, that may be the best way to do it. But you could also you could think about having, okay, anybody who falls into two categories. So for example, an elderly Black woman, two categories, they go to the top. A Latina woman who's living in a multi-generational home, or a healthcare worker who is an immigrant from Africa, for example. Those two things could go together, and those people would go to the top. And basically, the right-hand side is a repeat of what I have said before. And so, thankfully, we have time I really want to know what you think we should do to bring more justice to BIPOC communities, especially children. And how do you recommend we reach for health equity? I will say this is a picture of some providers in Spain who, as part of the recovery program for COVID-19, they bring their patients out to see the sea, which I thought was a lovely way to end this.
Thanks, Denise. This is Doug Opel again. I'm going to moderate this discussion, and I'll begin with reading some of the great questions that have already appeared, Denise, in the chat box. And as a reminder to folks, if I read your question and you have a follow-up question for Dr. Duzinski, please unmute yourself and feel free to ask that. So one of the first questions in the chat, Denise, was from Ken Feldman, one of our physicians, saying, given the well-deserved suspicion of African Americans of being medical experimental subjects without adequate protections, how do you feel their new vaccine acceptance will play out versus their greater risk from COVID?
Great question. I don't have a great answer. That is the question, right? So if I think we need to talk to those communities and find out how open they are. I mean, because there are a number of communities, including healthcare workers I've spoken to, who are skeptical about the first batches of vaccine that come out, particularly if they're rushed due to political pressures. We certainly don't want to have the groups that we have historically, committed violence against and used as guinea pigs in these kinds of medical experiments. We do not want to have those folks at more risk in the beginning. So all of these questions are really tough, but it's really about, once we get that, what I'm trying to narrow in on is, once we know we have an effective vaccine, let's allocate it exactly as we should, but we need to know it's effective. So there you go.
Yeah, thanks, Denise. Ken, do you have any follow-up questions?
No, not really. I'm just wondering how it'll play out.
Yeah, I agree with Denise. If I could just add one comment here, is that as I agree with Denise, some of the communities that potentially could benefit most from something like a vaccine, there have been maneuvers that have undermined the trust in those therapeutics among those communities. So we have to do better at transparency, involvement of those communities, engaging them, understanding their concerns, so that when a vaccine is available, assuming it's safe and effective, that high acceptance will be what we see. So I'm going to move to the next question. Thanks, Ken. From Jeff Sconyers, saying fear, overwork, and despair are associated with healthcare worker self-harm, including substance abuse and suicide. How will failing to prioritize healthcare workers affect the risk of additional self-harm?
Well, it's a great question. And do you have some data about how that's playing out these days under these circumstances? Are we seeing a higher incidence among healthcare workers?
Jeff, do you want to unmute and comment?
Denise, I haven't done the studies. I'm just a dumb lawyer. But what I've read is anecdotal. Certainly, there have been some suicides, and there's more chatter about people leaving professions or undertaking, alcohol or other substance abuse, and just generally feeling abandoned by the system because, frankly, healthcare workers, especially early on in the pandemic, were pretty much abandoned by the system. So this is more an issue about how do healthcare workers feel about putting themselves at what they perceive to be heightened risk if they're not even going to be prioritized for being taken care of.
Well, I do think that the risk that you're talking about is super important. I mean, we don't want this, what I've described here, to be another example to many healthcare providers of feeling and being abandoned. I think what we can do is other things, like clearly so for example, the thing that's causing, at least in my world, some of the most pain and suffering now are visitor policies. As people are trying to support families who are dying or who are sick, and we're limiting the visitors that are coming in, there may be other ways, including getting much, much, much more help and support for healthcare providers. There may even be ways we can compensate them in different ways. I'm not in charge of that kind of stuff, but there may be other ways we can show them how much we care about them and to provide the special kind of supports that healthcare providers need because of the special kinds of service they provide. I am not right now ready to say that translates to priority for vaccines, but many people disagree with me.
So I just say that this is one of the potential unintended consequences. You've already identified a huge number of unintended consequences of our current approach, and it's just one thing to think about and take into account. I don't know that it should necessarily affect what we do, but thanks.
Yeah, thank you.
Denise, a follow-up question here is really at the core of your argument is that reciprocity really is justified to prioritize healthcare workers, but the magnitude of harm to our BiPOC communities seems to sort of rise above that even. So, but that can be a difficult sort of weighing to justify. Can you tell us more about what was really driving that determination for you?
Well, I guess the thing about it, I guess the first thing that comes to mind is, while absolute reciprocity is owed to healthcare workers, not just healthcare workers, right? So other essential workers who are out there also, putting themselves at risk in jobs that are not terribly risky at baseline and now have all of a sudden become risky, like driving a bus or working at the grocery store. So the only part of that is, if we talk about reciprocity, it needs to be a broader group that we're talking about. And now there are things that are distinctive about healthcare workers and first responders. I am not one myself. I stand with all of you and I care very deeply about you. And again, I go back to what are the other ways we can honor that reciprocity absent this way, unless we're going to bring tons and tons of people into that fold for reciprocity.
Thank you. Okay, I'm going to move on to another comment, but potentially deserves some more discussion. So what's written here in the chat box is, I wonder if patient contact time should become the measure, so or a measure, and concentrating therefore on ICU, ER staff, and nurses. Wondering if you have thoughts, Denise.
So maybe, I think we want to see how protective PPE is. There was one small study I saw where, and it was small, but they tested a bunch of people who were doing aerosol generating procedures with PPE. And they found, for example, that anesthesiologists, nobody got sick, suggesting that PPE was effective. So I think it may have to do with people, again, to your point, who are coming into contact with those potentially or infected patients more frequently. So it may be stratifying that way. We would need the data to help get us there. It's a good point.
Okay. And I'm going to, there's a question from Dr. Jennifer Katz. Jen, go ahead and unmute yourself if you want to ask.
Hi, Denise.
Hi, Jen.
Free talk. I guess I'm curious, it feels like we're living in a sort of uniquely dysfunctional, unfair world at the moment. And I'm wondering what your thoughts are about if there's a vaccine distribution scheme that's terrible, or if hospitals aren't supplying adequate PPE to their staff. What level of action do you feel like is justified from healthcare workers as individuals? Should we all go on strike? Should we come up with our own vaccine distribution guidelines, even if CDC is saying something else? I guess I'm wondering, the system feels super broken right now. What should we as individuals be sort of focusing on?
Well, that's hard. As usual, I get a hard question from Jen. Okay, so one thing is, if there is inadequate PPE, healthcare workers have a stronger claim to vaccine allocation. So it's completely dependent on those things, right? So that's number one, right? And then I don't know. It's just such, what do you think? I would love to know what a health, I'm loath to propose anything since I don't provide direct patient care. What are some of the options?
No, now I just feel good that I stumped you and we can just move on and end this lecture.
Okay. I'm stumped. Anybody want to chime in? Feel free.
Well, there's a few other questions that may help draw this out a little bit. One is from Aaron Whiteman saying, Denise, you have framed your discussion in terms of crisis standards of care. As you note, crisis standards have not been declared. And you also note disparities in health outcomes for emergence and morbidity of disease existed before COVID and without change will continue after COVID. How do you see your ideas impacting how health or healthcare should be delivered or approached in a non-crisis standard of care, or even after an efficacious vaccine has been widely distributed?
So one thing I would say is I definitely was using crisis standards of care as an example in a few places. However, I think a public health ethics standard, which I think we're in. You don't have to call it crisis standards of care yet for us to be there. It still has that other orientation toward the common good. And so I think day to day, people are trying to balance those things as best they can while trying to still kind of execute the usual standards of care to the best of their ability. It's a kind of an impossible situation, but I wouldn't say that this analysis applies only to crisis standards of care. It applies to a pandemic of this magnitude affecting this many people. I think that some of the priority, I mean, the obvious answer is, providing better health care insurance, for example, universal health care would be a way that you would address a whole bunch of these things at once, right? And something that I would support from a national standpoint, right? You'd address outside of this pandemic, you'd be able to address access issues and a bunch of other issues. But this is a really complex question and issue that, yes, it needs to, this kind of prioritization needs to keep happening. How it will happen, I think probably depends a lot, even intervention by intervention, depending on how those things affect those communities, those illnesses.
Thanks, Denise. I want to also just come back to something you started off with regarding the distinction between equality and equity. And you said something like, equality looks right on paper. And in fact, some of the initial triage algorithms really focus on equality rather than equity. So help us understand, is this a paradigm shift that we're really just starting to grapple with? Or why does it seem like equality still should be right here, at least on paper?
Well, I think probably it depends on where you stand. I think probably some people on this call have for a long time not thought equality was the fair approach. But I do think some of us can, I will say myself, for example, who have not been on the receiving end of discrimination and a lot of the violence that other communities have experienced, it looks right to me because, in part, I assume that when I enter into the healthcare system because I need help, I'm on equal footing with the person to the right and left of me. But really, I have more than a bunch of the people to the right and left of me. And in fact, those people are standing behind me instead of next to me, which ends up being a real problem when you start talking about needing critical healthcare resources when you're super sick. So those people with these comorbidities, they're not coming in next to me who haven't had good health insurance and some of those issues are not well controlled medically because we're not on equal footing. So equality doesn't make sense from the get-go. I think we really need to stand in our other people's positions to see what does this look like from here and really listen to those groups to better understand what steps toward equity make the most sense. And we will get differing opinions, but we might help move the whole needle in the right direction.
Great, thank you. So last question here, as it's 8:59, from Ben Wilfon. If PPE is quite effective, there may be a few healthcare workers who are sick, but for those who work in ICUs who do get sick, it's not clear that, I think what you mean here, Ben, is PPE is generally effective, should justify not prioritizing care to that ICU nurse. Ben, do you want to clarify, did I get that right by unmuting?
You did. It was really focused on Denise's comment that the relative effectiveness of PPE would be important in whether or not a sick healthcare worker should be cared for. My point is that whether it's effective, even if it's really effective for that particular nurse who gets in the ICU who gets sick, why would the fact that it's effective or ineffective be relatively important to deciding whether that person should be prioritized for care?
It's only important insofar as standing next to that nurse are Black, Hispanic, and other people who also need that resource. And the question becomes, which of these people should get a resource that we may not have enough of? It's only relative to other people. Everybody deserves the resource. Let me be really clear about that. Every person who needs these resources deserves them, and we want to give them to them. But if we don't have enough, then who gets to go first? Who stands in line first? You're raising a really good question, Ben, and that's my answer.
All right. Thank you very much, Denise. It's 9 o'clock and we have to end. We really appreciate your talk and we learned a lot. Thank you very much.
Thank you. Have a good day, everyone.